What is new about this data and what do we learn from it?
Well, the OPTI-1 study was designed on the heels of IL-1, and there were a couple learnings out of the IL-1 study. One was that it worked, liver-directed insulin, or HDV insulin being developed by Diasome, worked very well in patients who were poorly controlled at baseline, meaning that they had a hemoglobin A1C greater than 8.5. And what we showed in that study very nicely was that we were able to decrease hemoglobin A1C over a 6-month period of time with both tighter control with Lispro or HDV Lispro. But the difference was in those patients who were on HDV Lispro, their time less than 54 or level 2 hypoglycemia actually went down by more than 50%, where those who were on Lispro went up by more than 50%. So a real different cost to the patient, if you will, for getting tighter control. And this is a challenge on a day-to-day basis. Do I tighten my control, or do I risk risking hypoglycemia, or do I risk long-term consequences of hyperglycemia? Also in IL-1, what we learned was that well-controlled patients, meaning an A1C less than 8.5, didn't change their bolus dosing, didn't really change their basal dosing, therefore had a null effect in IL-1. And what we did was design the OPTI-1 study with a few thoughts in mind. One was how best to use a hepatically targeted insulin in well-controlled patients so that they can benefit from less hypoglycemia, and is there less hypoglycemia in that population? And the second question was, is there value to hepatically targeted insulin on top of state-of-the-art care, which is really well-controlled insulin titration and unblinded, not blinded like in the IL-1 study, but unblinded continuous glucose monitoring, or CGM. So what we did in the OPTI-1 study was we enrolled patients who only had an A1C between 6.5% and 8.5%. So well-controlled patients from that point of view. And on average, they had a hemoglobin A1C of 7.3 when the study started. 80% of the patients were naive to CGM. So all of the patients ended up on the Dexcom G6 CGM system. But again, 80% were new to it. And then we titrated their insulin levels, both basal and bolus, to get to a fasting blood sugar between 80 and 100 milligrams per deciliter. So we achieved that. And we did all that over a 90-day period. So the benefits of CGM, as we've seen and others have demonstrated, is between 2 to 6 weeks. And during this 90-day opt 7.3 to 6.9, so they were better controlled on the CGM, as many have shown, and they decreased their hypoglycemic event rate, particularly at night, from about 1.4 events per week to about 1.1. After the 90-day optimization, all the patients in an open label fashion were changed to HDV insulin for their bolus insulin. But they were randomized to decrease their basal degludec by either 10% or 40%. The reason we decreased the basal was, again, to encourage patients to manage their blood sugars with bolus HDV insulin and try to push their bolus dosing, because it's the addition of the HDV bolus dosing that allows the anti-hypoglycemic effect to be used or achieved. So we did that for an additional 90 days, and on a weekly basis through the trial sites, the basal insulin was titrated either up or down based on what they needed, being on the HDV insulin. At the end of the 90-day HDV period, what we saw was really quite interesting and exciting. First of all, they all titrated back to their original basal dose. So at the end of optimization, they were on 0.31 units of degludec per kilo per day. And by the end of the HDV period, they were as well. But the patients on the HDV bolus were actually on 0.03 units per kilo per day more bolus insulin. So any effects we had on hypoglycemia were not because patients were on less insulin. In fact, they were on a little bit more insulin. But what we saw was a further 25% reduction in nighttime hypoglycemic events. So the combination of CGM and tighter control was a 20% reduction. The addition of HDV insulin to CGM further lowered nighttime hypoglycemia by 25%. So overall in the study, the patients in the trial reduced their nighttime hypoglycemia by almost 46%. They decreased their daytime hypoglycemia as well, and their 24-hour hypoglycemia by about 20%. So the addition of HDV insulin in well-controlled patients per our goal, when able to modify their basal transiently so that they can put themselves on a good dose of HDV Lispro bolus insulin, does lower hypoglycemic events. Furthermore, HDV insulin or hepatically directed insulin does have further anti-hypoglycemic events on top of continuous glucose monitoring. Achieve the goals of the study, and I think it shows the power of needing to have open label CGM in these studies so patients can see where they're at and they can push their bolus dosing such that they can achieve the anti-hypoglycemic effects that hepatically targeted insulin offers them. All these data are consistent with the putative mechanism of action, whereas if you insulinize the liver is able to take mealtime blood sugar, make glycogen, store that glycogen until a time when the body needs it to improve or prevent hypoglycemia, particularly at night, which is what we saw in our study.
What does this reduction in hypoglycemia mean, or hypoglycemia events mean for patients in a real world setting?
Well, in a real world setting, it's, it only takes one bad event to have a poor outcome. So you're right, the fewer events patients have, the better off they feel. And I think by decreasing events, we offer the opportunity for more aggressive insulin use to ultimately lower the long-term consequences of hyperglycemia, which is obviously the apathies of neuropathy, retinopathy, nephropathy, and those. So I think this offers them the opportunity to more tightly control their blood sugar. The fact that we're improving glycogen storage, and all our data would agree with that, offers them, and they're able to decrease their basal to bolus ratio by about 15%. So that allows patients better control over the day of their blood sugar instead of committing to a basal dose and being stuck with that dose the rest of the day. So when it comes to exercise and other things that can modify how you use your blood sugar or your glucose during the day, control over that with bolus dosing and then glycogen storage, I think simplifies their routine beyond just the minimization of hypoglycemia.
Is there anything else that you think it's important to touch on when interpreting the results of this study?
Well, I think, these are further data that show the safety of HDV insulin or hepatically directed insulin that we're developing. I think it's worth noting we had no liver side effects. There were no adverse events attributed to the drug, and this just continues the clean safety profile that we've observed last years.